Good afternoon. Welcome you all for monthly CME program in 2024. Today we have two important presentations. First presentation will be on Scleromyositis, the new kit on the back. It's presented by Dr. Dhanushka Karunaratne, consultant rheumatologist and teaching hospital, Batticaloa. Over to Dhanushka.
Good afternoon, everybody. Today's topic as a clinical entity is not that unfamiliar to us rheumatologists. However, based upon its clinical characteristic, pathophysiology, and the histological findings, the way we look at it has dramatically changed over the last couple of years. And before talking about the condition, let me share with you one of the cases that I've come across at Batticaloa quite recently. And this is a 46-year-old mother of two kids from Eraur, presented giving us 5-month history of skin sclerosis involving the circumoral region, hands and feet, associated with typical Raynaud's phenomenon, and that this was diagnosed as limited systemic sclerosis by the dermatology team. However, she presented with progressive proximal muscle weakness over a 1-month duration, and at the time of hospital admission, which is our encounter with the patient, she was bedbound with severe generalized muscle weakness, which is associated with bulbopharyngeal involvement resulting dysphagia, and she had neck muscle weakness too, which has progressed over a period of 2 weeks. And before becoming bedbound, she complained of exertional dyspnea, which has progressed over the last couple of weeks as well before presentation. And at the time of presentation, we knew there's muscle pathology in the background of systemic sclerosis. And our main concern, since there's bulbopharyngeal and neck flexor involvement, was the respiratory muscle involvement. However, at that time, the ABG on admission was normal, and so was the single breath count. We did a 2D echo to look for a cardiac involvement, and 2D echo showing ejection fraction of 40 with impaired LV function. Since ProBNP was not available to us, we did troponin I, because troponin T in muscle pathology is not reliable indicator. And it was normal, and so was the ECG, not showing any arrhythmias or any changes. And she came with an HRCT, which was arranged by the dermatology team, which was showing interstitial lung disease, which was mild, reported as an SIP. With regard to the blood, she had raised inflammatory markers, transaminitis with AST significantly higher than ALT, showing the skeletal muscle origin. And renal functions were normal. But the striking feature, as expected, was the significantly raised creatinine phosphokinase, which was in 4,000s. And then with regard to the immunological test, which was done during the course of the illness, the ANA showed positivity at a titer of 1,320 nuclear pattern. And interestingly, the anti-centromere and anti-SCL anti-topoisomerase, that is SCL70, was negative. SSA anti-Rho was borderline positive. And then finally, subsequently, we managed to arrange a myositis profile, which showed a strongly positive anti-KU antibody. And then the muscle biopsy also demonstrated the perifascicular and endomysial inflammatory changes associated with scattered necrotic fibers around the inflammatory background, which was reported as polymyositis by the pathologist. Upon arrival, on the day of admission, we made the before some of these investigations were available to us, we made the tentative diagnosis of systemic sclerosis overlapping with inflammatory myositis, complicated with oropharyngeal, neck flexor, and cardiac muscle involvement. No, we knew that we are not we are dealing with bit of a tricky situation because this is a full-blown florid myositis. Hence, we started IV steroid. In parallel line, we started on the day first the IVIG, the total dose of 100 mg over 5 days. With the cardiologist input, patient was put on ACE inhibitors and diuretics. And from the day one, we had to NG feed the patient because of the severe bulbopharyngeal involvement. However, after 5th day, although there was some improvement in the bulbopharyngeal and neck flexors, and there was no evidence to prove impending respiratory involvement, muscle involvement, plus the CPK was also reducing and came down to 1,800. We were not very pleased with the response, and it was not very promising, the response to the both induction agents. Hence, we thought of starting rituximab at the beginning of the second week, and the first dose was given. And after a couple of days, we got a call from the ward that the patient is in impending respiratory arrest, and they had to intubate the patient electively and shifted to the ICU. And ABG at that time showing severe respiratory acidosis, indicating respiratory muscle failure. CPK was again raised back to 3,000, and we were worried. There was a short brief history of hyperenthusiastic chest compression, and we wondered whether the high CPK was a part of the CPR. However, the other thing was the active disease. Latter was the most likely. And the patient started on IV hydrocortisone. Repeat chest the chest X-ray and the 2D echo at the ICU were not showing any interval changes. And we waited for 1 day, and after that, patient continued to remain on high ventilatory support, and CPK was high, so we had to actively intervene. And at that point, the question was whether to start on the IV cyclophosphamide, which is the other option for the refractory myositis. But with my past experience and considering the critical situation patient was in, and I opted for IV, the plasmapheresis. And we thought of giving a plasmapheresis and then stabilize the patient and then to administer cyclophosphamide was the plan at that point. So we gave 5 continuous cycles, 5 days plasmapheresis. But that time there was a significant improvement. So we were able to wean the patient off from the ventilatory support, and CPK came down. But at the end of the thing, she was due for her second dose of rituximab. When we knew that rituximab take a while to kick in, so we thought of continuing the second dose of Ritux. The results was promising. Patient was improving. And then NG came out, and we changed the patient to oral drugs, oral steroid. Mycophenolate mofetil was started, and the physiotherapy. So now the 2 months post discharge, so we didn't give cyclophosphamide. 2 months post discharge, now the patient is able to walk with minimal support. CPK remained less than 400s now. 2-deco is reassuringly normal and currently doing very well on 2 grams of MMF daily with other medications and low dose steroid. So with that, talking about inflammatory myositis, which is very well known to overlap with other autoimmune connective tissue disorders, as we know. And out of that, scleroderma being the commonest, with rate of like 40% of the cases of overlap myositis are with scleroderma. And historically, this combination was termed as scleroderma myositis overlap syndrome. However, most of the authorities revisited this based upon main 3 domains, that is the histopathology, immunology, and clinical characteristic, and they identified this as a new disease entity rather than an overlap phenomena. And this talk is about that and what made them to do so. So this crowded slide tabulate these 4 domains, which I'll be talking to you about in the future slides. So talking about the clinical features, it's very well observed that scleromyositis, as opposed to the isolated disease, has high prevalence of other tissue or the other organ involvement, mortality, and morbidity. Talking about the muscle involvement, in scleromyositis, or this overlap syndrome, which was previously called overlap, it's been observed that the hands are more affected than the lower limbs. And sometimes because of the associated scleroderma, the skin thickening, contractures, and arthritis contribute to the distal muscle weakness too. And if you look at the survival rate of the scleroderma, it's obvious that it's always they have the worst survival rate as opposed to the isolated diseases. And when it comes to lung involvement, interstitial lung disease is more prevalent in this overlap situation. And the respiratory impairment could also be contributed by the respiratory muscle weakness. And when it comes to the cardiac muscle, we all know that scleroderma is notorious to cause sudden cardiac deaths due to arrhythmias, which is common in scleromyositis too. And in addition to the frequency of cardiomyopathies, or the myocardial involvement is high in the overlap compared to the isolated myositis. And when it comes to the renal scleroderma renal crisis, which is the 3rd common cause of death in scleroderma current nowadays, some studies indicate it's 4 times higher than that of the isolated scleroderma without muscle involvement. This is more so when there's PMSCL antibody positivity. And we all know that in scleroderma, if we have RNA polymerase, we say that we have high preponderance, high incidence of renal crisis. Whereas in scleromyositis, when it overlaps with myositis, the PMSCL is the antibody that put you at renal risk. That could also, some authorities suggest this could be contributed by the liberal use of steroid in myositis, because we all know if you have scleroderma, you have to be extra cautious to put somebody on higher doses of steroid because of the risk of renal involvement. But however, when there is myositis, we sometimes got to use higher doses of steroid to prevent life-threatening complications of myositis. So when you are using higher doses of steroid to manage myositis in the background of scleroderma, the renal crisis is a concern. In addition to these things, even if you look at the other domains such as skin involvement, GI involvement, arthritis, which are all prevalent, and the morbidity is significantly higher in the overlap situation. The second domain is the autoantibody. Now, classically, if you look at the classification criteria for scleroderma, you can identify three major antibodies described in those, for instance, ACR, EULAP classifications, and so on. They're namely the SCL70 anticentromere and anti-RNA polymerase. But interestingly, none of these major systemic sclerosis specific antibodies aren't strongly associated with the scleromyositis, and instead it has its own and set of antibodies associated with it. In fact, the antibodies like anticentromere are usually negative when there's muscle involvement in sclerosis. And if anti-topoisomerase, that is SCL70, if it's positive, it is associated with which is if positive, it's rare, and then in which case it is associated with myofibrosis and poor outcome. And if you look at the existing criteria, such as EULA-ACR, they do not give any consideration to these novel antibodies in the classification, hence contributed to low sensitivity of identifying scleromyositis or overlap myositis in the setting of scleroderma. Now let's look at what are those antibodies that are linked with scleromyositis or this overlap phenomena. So the first two described was anti-PMSCL. So anti-PMSCL antibody in 30% present in 30% of scleromyositis cases, and it is linked with limited cutaneous involvement or limited sclerosis, scleroderma. And there's always high incidence of ILD and renal involvement or renal crisis, despite which they are doing well and they are treatment responsive. The other more common antibody variety, like in my case, is anti-KU, anti-KU antibody, which can be present up to 50% of the cases. And the other organ involvement, like interstitial lung disease, cardiac, arthritis, skin disease, are all more common with this antibody. And in the biopsy, you usually see a necrotizing pattern instead of vasculopathy. And their prognosis also comparatively bad as opposed to PMSCL scleroderma. And there are novel antibodies describing which are linked or associated with this condition, such as U1RNP, U3RNP, RUB, BL12, and SMN. And you know the U1 and U3 are linked with other CTDs as well. So the list is expanding with the invent of new novel antibodies. And so the association with a separate set of antibodies rather than disease-defining antibodies also against the theory of overlap phenomena. That one thing that they highlight. And then let's look at the histopathology. So in the biopsy, the European Neuromuscular Center is the main authority that classify or categorize the histological patterns of idiopathic inflammatory myositis. So they identify 5 categories, named the polymyositis, dermatomyositis, necrotizing myositis, inclusion body, and the non-specific, and they do not give any recognition to scleromyositis to date. And however, if you look at the biopsies of scleromyositis, 3 major characteristic features which are not seen in other subsets of the scleroderma myositis spectrum can be identified clearly. So they are namely the vasculopathies and endomysial fibrosis. So talking about the vasculopathy, which is the commonest finding peculiar to scleromyositis, under light microscopy, a Chinese stain, you can appreciate the capillary dropouts and enlargement of the capillaries under light microscope. And if you put immune histochemical agents such as VEGF that shows abnormal expressions, and under electron microscope, the basement membrane, like in this case, the basement membrane reduplications, and the increased number of podocyte in the capillary with their processes can be appreciated. So these are the changes they describe under vasculopathy. And the second histopathological feature is fibrosis. Fibrosis is not unique to any form of myositis. However, fibrosis without background inflammation or without background necrosis at early stage in the perimysium is quite pathognomonic and can be seen up to 20 to 30% of the cases of scleromyositis. And if it's associated with fibrosis without any background necrosis and inflammation, they say that increase the mortality and morbidity because they become treatment, particularly steroid unresponsive. And if you see necrosis and inflammation in the biopsy, which is quite promising because that indicates the steroid responsiveness and good prognosis. So these are the three domains. Now their main argument is if it is an overlap phenomena, that you should be able to identify the overlap features peculiar to each conditions, or rather than overlapping with each other, rather than having new findings, like in this case. Whereas in scleromyositis, these changes are not seen elsewhere or other conditions or other subsets of this spectrum. Hence, they strongly believe that this should be treated as a separate disease entity and renamed as scleromyositis rather than the overlap. When talking about the management, we all know up to now that you recently had a lecture also, the randomized controlled trials showing the efficacy of our familiar agents such as mycophenolate, cyclophosphamide, tocilizumab, rituximab, nintedanib, and even hematopoietic stem cell transplantations are effective in the management of scleroderma when it's associated with interstitial lung disease or the skin sclerosis. However, there are no large studies to suggest their efficacy when muscle involvement is present. And so talking about the steroid, as I told you earlier, we always have to weigh the potential benefits of using steroid against the myositis versus the potential harm that it can do to scleroderma component. And it says that studies like ISRC shows that every 1 milligram of prednisolone increased the death rate by 4% in scleroderma due to renal crisis. So higher doses of steroid are toxic. Unfortunately, when there's a myositis component, we have to use steroid liberally to bring the inflammation down, which could also be attributed to the high incidence of long-term mortality in scleromyositis subset. So this is, I told you earlier, by looking at the immunology and the biopsy, you can predict the disease outcome and treatment response. So if you have a necrosis and inflammation in your biopsy, your scleromyositis is going to be steroid responsive. And if there's only fibrosis without any background necrosis or inflammatory cells, so it's going to be a problematic case, treatment resistant case. And talking about the immunomodulatory therapy, in most of the studies have identified mycophenolate mofetil being the commonest, most frequently used drug as an immunomodulator in scleromyositis or in this overlap phenomenon. Others being methotrexate and azathioprine. However, to date, we don't have enough data for their efficacy in scleromyositis. They've shown some efficacy in myositis alone and in scleroderma. In contrast, IVIG is the only agent to date showed some efficacy and steroid-sparing effect in scleromyositis subset, or the patients who have this overlap. And then if you look at even the recently in the sense in 2022 BSR guidelines suggesting the rituximab and abatacept as a treatment for refractory myositis. And on the other hand, we have new evidence coming that rituximab as an emerging therapy, particularly to treat the skin and lung in scleroderma. So rituximab could be a potentially a candidate, but we don't have data to date. And finally, for very refractory cases, for all these, for scleroderma, autologous hematopoietic stem cell transplantation is also an option. So in summary, currently our understanding is the scleroderma inflammatory myositis is not an overlap. When present together, is not an overlap phenomena. It's should rather be treated as a separate disease entity based upon the histological, immunological, and pathophysiological evidences. And so they are the main hallmarks. These are separate set of antibodies, and the histopathological findings are the hallmark of that disease entity. And we badly need a tailor-made management for this entity rather than using the treatment guidelines advocated for myositis and scleroderma, which we are doing currently. So that is what they are showing. Because we know that scleroderma is not doing well. They're not doing well because we are using someone else's, another disease management protocols for another entity is the main argument, and it's open for discussion. So these are my main two references, and it's open for discussion.
Especially in your case,
yeah.
Was my
why I didn't use cyclophosphamide?
Yeah, or didn't go probably do, but yeah. Even when you look at the drugs, they are not studied that much.
Yeah.
This, but
so I did with my personal experience. As I told you, cyclophosphamide was the option when my patient didn't immediately respond to rituximab. At that time, patient was intubated and ventilated and in a critical situation. So I have limited experience with cyclophosphamide, and it used to critical in patient with multi-organ failure. They are not doing well at all. So my objective was at that time to stabilize the patient first and to start cyclophosphamide actually. And my stabilization at that time was with plasmapheresis. I thought because it's not going to do anything. And at that time, I did mention we were treating the infection aspect. So there was a bit of aspiration as well. So we concurrently we were giving high antibiotics, both spectrum antibiotic. So it is true, sir, that cyclophosphamide definitely has a place for refractory myositis, but patients were remarkably responsive to the plasmapheresis, and then she was due for the second dose of rituximab. And we all know these immunomodulators take time and a while to kick in. So this incident happened, the respiratory paralysis happened just next day after rituximab. So I thought we didn't give enough time for rituximab to kick it. And by the time we gave the plasmapheresis plus the rituximab plus IVIG, we remarkably well, and we were watch and wait, and the next option was ready, that was cyclophosphamide. So since it's responsive and doing well up to now, we will continue, but definitely should the patient flare up again, it should be cyclophosphamide.
Regarding the who and what, if the present ILD development is 5 years long.
Yeah.
So what about your are you going to
she's already diagnosed with ILD by the dermatologist. She had because this was it's a very fresh case, madam. So this was 5 months history of sclerosis and over a month developing overlapping with myositis. And she presented 3 months before to the dermatologist. They didn't refer to me. I got the referral because of the muscle involvement. And they've arranged just about a couple of weeks, maybe 1 month before hospitalization, she had just a screening HRCT because she had mild respiratory symptoms, which showed background interstitial lung disease, which is NSIP factor, except which is what we see in scleroderma. What is Madam's question?
If the patient don't have any ILD, will you go for screening of interstitial lung disease?
For the scleromyositis patient,
Yeah.
I think we have to actively and vigilantly look for lung involvement with these symptomatologies, chest x-rays and all, and then yes, I would rather say yes, because the ILD incidence for the scleromyositis or this overlap, they say up to 70%, which is a very high rate. So screening is definitely beneficial. Yeah.
Okay, so the follow-up plan. The follow-up what has happened to the patient now? The muscle inside, weakness.
Yes, that's all right. In the follow-up, now patient is on mycophenolate mofetil 1 gram BD and steroid about 10 milligram. And now she is able to walk with assistance thanks to my physiotherapy team and doing very well. And to repeat to the echo is very promising and not showing any effect. Rejection fraction is normal. And the one thing I didn't discuss here is scleromyositis could be a paraneoplastic or a cancer-related malignancy, which I didn't do any screening here for this patient. And she fulfilled the criteria because this is a resistant myositis, and they say old age, resistant or refractory myositis, and it's particularly associated with HMG and this necrotizing. There are separate set of antibodies where you go to screen the patient. And my patient fulfilling some of the, if you look at even the BSR new guidelines, some criteria, and you can't, in our resource poor setup, you can't order everything like in a single go. So apparently, probably everything is immune rather than underlying malignancy since she's doing well and thing. But we are planning a CT, chest, abdomen, and pelvis as well. No, there's no any recommendation for this entity. This entity is very, very novel, and this entity has been published in 2023. Recognizing this as a separate clinical entity. That this discussion has been ongoing for about more than a decade to treat or consider this as an entity. But in fact, actually the histological findings and the immunological findings made them to consider this as a separate entity rather than overlap phenomena. So what they highlight in this, you have these references. What they highlight is we badly need a management protocol or research or studies more upon this to see and what suits more. Particularly, it's a very valid question, the steroid, the amount. Are we using 1 gram? Are we using high doses steroid for a patient who has a background of sclerosis and putting them at a risk of scleroderma renal crisis and renal involvement is one of the key concern of these studies. And that's why they are urging for a new set of guidelines or new set of treatment plans through studies. So we don't have at the moment. We are just using as for myositis, ordinary myositis.
Thank you, Dhanushka, for very informative and eye-opening lecture on scleromyositis. So our next presentation will be by Dr. Nirooshika Illanko, Senior Registrar in Rheumatology and Rehabilitation, Colombo South Teaching Hospital. The topic on reality. Over to Nirooshika.
Good afternoon, ladies and gentlemen. Thank you, sir, for the kind introduction. First of all, I would like to thank the College of Rheumatology and Rehabilitation, Sri Lanka, for giving me this great opportunity. So let's move on to my topic, rare reality, where I am going to discuss a case scenario followed by the disease discussion. So let's move on to the case. My patient is Mrs. Y, a 64-year-old patient. She is a housewife from Piliyandala without any prior comorbidities. Presented to our clinic with a history of pain, swelling, and induration of skin involving both legs for 2 months duration. It predominantly involved anterior portion of both shins. She had sudden onset of pain around the ankles. Later, it involved to the proximal legs in symmetrical fashion. She had severe burning pain in lower legs. There were no triggers such as recent history of trauma or recent drug histories were identified. And there were no other joint symptoms or muscle pain or muscle weakness or significant systemic symptoms. But she had loss of appetite. There was no history of fever, sore throat, dysphagia, dyspnea, palpitation, and drug intake. There was no similar episodes in the past. In search of differential diagnosis, there was no history suggestive of Raynaud's phenomenon, gastric dysmotility, exertional dyspnea, and digital ulcers. There was no history of hyperglycemic symptoms, and she was not on supplements like L-tryptophan or 5-hydroxytryptophan. She is not a diagnosed patient with advanced chronic kidney disease, and there was no environmental exposure to adulterated rapeseed oil, and there was no family history of autoimmune disorders. There was no significant past medical or past surgical histories. She was not allergic to non-foods and drugs, and there is no family history of autoimmune diseases or malignancies. She is a housewife. She has 3 children. She also has good economic and social support. So the examination findings, on general examination, she is an averagely built lady with a BMI of 22.3 kilograms per meter squared. She is afebrile, mildly pale, and not icteric. She had indurated thickened skin and brownish discoloration in both lower limbs, along with positive groove sign and tenderness in both legs, which is more prominent in the right side more than the left side. There was no evidence of synovitis. The range of movements of all joints were normal, and there were no clinical signs of systemic sclerosis and no evidence of muscle weakness. This is the groove sign presented in our patient. I will discuss about that later. In systemic examination, the cardiovascular system, respiratory system, abdomen, and central nervous system examinations findings were normal. So, in summary, a 64-year-old patient with pain, swelling, and induration of skin involving both legs for 2 months duration. Initially, she developed the above symptoms around the ankles, which later involved proximal leg in symmetrical fashion. She had constitutional symptoms, and there was no history of fever, sore throat, dysphagia, dyspnea, palpitation, drug intake, diabetes, and Raynaud's phenomenon. On examination, there was symmetrical thickening and brownish discoloration were noted in both lower limbs, along with positive groove sign and tenderness. The general physical and systemic examination findings were unremarkable. So, what could it be? Whether is it a scleroderma, either localized or systemic. Or it could be a sclerodema, which usually occurs in diabetic patients. Or it is an initial cutaneous manifestation of any hematological malignancies. Or anything else. So we have done some investigations. In the full blood count, This patient had mild eosinophilia with in the percentage of 10.1%, which is more than 500, and normocytic anemia and mild thrombocytosis. The blood picture again confirmed the presence of anemia of chronic disease and mild eosinophilia. The inflammatory markers, ESR was 110 millimeter in first hour and CRP was 10 milligrams per liter. We have done the metabolic screening to look for the organ involvement and to exclude some differential diagnosis. The liver function and renal functions were normal with the normal fasting blood sugar, normal thyroid function, and the CPK level is again normal. And we have done some specific investigations in this patient, which includes the x-rays of the legs were perfectly normal. Ultrasound scan of the lower limbs showed subcutaneous edema and there was no evidence of DVT. The antinuclear antibody was negative and we have done the skin biopsy which showed mild collagen degeneration and lymphocytic and eosinophilic infiltration in the dermis. So now, what are the thoughts? What's the diagnosis? Whether it could be a scleroderma. To say it's a scleroderma, the patient should have the skin thickening mainly in the hands and the feet. But this patient is lacking that feature. And again, this patient didn't have the Raynaud's phenomenon and the biopsy findings also against the scleroderma. So that is less likely. The second differential diagnosis was sclerodema, which usually occurs in diabetic patient. This patient is not a diagnosed patient with diabetes and her fasting blood sugar also normal. And again, in the biopsy, there is inflammatory features, which is absent in sclerodema. So that is also again less likely. So combining these features such as low limb pain, tenderness and indurated skin changes, which are not involving the hands or feet, in the absence of clinical symptoms and signs of systemic sclerosis, eosinophilia in blood and infiltration in the dermis, and high inflammatory markers. We have arrived at the diagnosis of eosinophilic fasciitis, which is a rare disease. So we have started this patient on high dose of oral prednisone, which is 1 milligrams per kilograms per day, with a tapering off regime, with a bone protective treatment as the patient has to be on long-term steroid treatment. And simultaneously, we have started on steroid sparing agent, methotrexate 12.5 milligram weekly, and the dose is titrated at 20 milligrams per week. The patient had a good clinical outcome, which is evidenced by the softening of the skin within 2 months of duration, and the inflammatory markers also started to come down. So this is the case. And this is the topic I'm going to discuss, which is the eosinophilic fasciitis. So what is eosinophilic fasciitis? Actually, it's a rare disease described by the presence of pitching edema, erythema on limbs or trunk, and later by collagenous thickening of the subcutaneous fascia. Hypergammaglobulinemia, eosinophilia, diffuse fasciitis. These are the features of eosinophilic fasciitis. It is also called as Schulman disease. This is the name of the one who has discovered this disease first and named it as diffuse fasciitis with eosinophilia, and later it is named as eosinophilic fasciitis. The etiology is unknown and pathogenesis is also poorly understood. So how common is it? As I said earlier, it's a very rare disease. About 300 cases have been reported. It is more common in Caucasians. It most commonly affects women than men, and it usually affects the adults. The etiology is idiopathic. So are there any trigger factors to develop the eosinophilic fasciitis? Yes, there are some trigger factors we have to look for. If a patient presenting with the features of eosinophilic fasciitis like skin thickening, scarring the hands and feet, we have to look for some trigger factors. And those are stimulus exercises, autoimmune diseases like SLE, Sjogren's syndrome, primary biliary cirrhosis, and thyroid disease, exposure to certain medications like statin, ramipril, heparin, pembrolizumab, immune checkpoint inhibitors, and anti-TNF agents, hematologic disorders like aplastic anemia, multiple myeloma, myeloproliferative disorders, initiation of hemodialysis, radiotherapy, and infections like Borrelia infection. Those are the trigger factors, and we have to search for them. So if we see the pathogenesis that is poorly understood, it is thought to be due to the autoimmune mechanism based on the clinical aspects. And laboratory results like this patient is having thrombocytosis, hypergammaglobulinemia, and inflammation in the biopsy report. Those are evidence for the autoimmune mechanism, and also some autoantibodies also could be positive in eosinophilic fasciitis, and they have a good clinical response to the glucocorticoid therapy. Thus, it is thought to be an autoimmune mechanism. There are several tissue markers are involved to promote the tissue fibrosis, which are increased fibronectin and type 1 collagen levels, which are secreted by the dermal fibroblast, increased tissue inhibitor of metalloproteinase 1, which promotes the fibrosis, and interleukin 5, interleukin 2, interferon gamma, leukemia inhibitory factor, and increase in the expression of connective tissue growth factor genes in the fibroblast. Those are the tissue markers. If we see the histological changes, initially the edema and the inflammatory infiltrate with the lymphocytes, plasmacytes, histiocytes, and most often eosinophils in the deep fascia and the lower subcutis. Then the fascia becomes thickened and sclerotic with the disappearance of the inflammatory infiltrate. After the degranulation of the eosinophils in the fascia, which extravasates the toxic and fibrotic potential substances, which leads to the fibrosis. And how do they present? The onset of the disease is often sudden. There may be any trigger factors can be there prior to the onset, as I mentioned earlier. The most frequent clinical features are the skin changes. That is the most prominent feature in eosinophilic fasciitis. And also arthralgia or arthritis can occur in 40% of patients. Myalgia or myositis can occur, and rarely neuropathies or serositis also can occur. If we see the progression of skin lesion, it is often bilateral, but unilateral is also possible. Initially, they develop a non-pitching edema for a full circumference of the distal limbs, and the edema is later replaced by the symmetrical induration with the puckering, the orange peel appearance. The typical change is a linear depression that follows the path of the vessels in the affected area, which is known as the groove sign, which is also presented in my patient. The skin and musculoskeletal manifestations. The skin lesions are more common in extremities, in lower and upper limbs, than the trunk, than the neck. And the hands and feet are generally spared. And sclerodecty is absent, not like systemic sclerosis. Irregular woody surface of the orange peel compared to the smooth, shiny skin found in the systemic scleroderma. And inflammatory arthritis can occur, which is usually around the indurated fascia. Myalgia and muscle weakness also possible. Do they involve major organs? Yes, they can, and they involve the major organs, but not like systemic sclerosis. The main differential diagnosis for this eosinophilic fasciitis, so to diagnose it, we have to exclude the systemic sclerosis. So not like in systemic sclerosis, the major organ involvement is rare in eosinophilic fasciitis. The neurologic manifestations are mono or polyneuropathies. The secondary carpal syndrome is possible due to the local compression of the median nerve. The visceral involvement is rare, but few reported cases are there with the pulmonary, pleural, renal involvement and the cardiac pericarditis. So, what are the differential diagnoses to be considered for the eosinophilic fasciitis? We have to think about the conditions which are associated with the skin induration, tissue fibrosis, and the eosinophilia. So the main differential diagnosis is the systemic sclerosis, and the others are the scleroderma-like disorders like nephrogenic systemic fibrosis, scleromyxedema, sclerodema, eosinophilia myalgia syndrome, toxicoil syndrome, graft versus host disease, and some systemic diseases like malignancies, autoimmune diseases, or infections. So as I mentioned earlier, we have to differentiate it from the systemic sclerosis as it is included in the classification criteria of eosinophilic fasciitis. So these are the differentiating features. Raynaud's phenomenon is present in systemic sclerosis and which is absent in eosinophilic fasciitis. The capillary architecture is disorganized in systemic sclerosis and normal in eosinophilic fasciitis. The digital pitting scars are present in eosinophilic fasciitis. Involvement of hands, feet, and face are there in systemic sclerosis and absent in eosinophilic fasciitis. Internal organ damage is present in systemic sclerosis and which is rare in eosinophilic fasciitis. Specific autoantibodies like ANE and SCS70 antibodies are present in systemic sclerosis and usually absent or rarely present in eosinophilic fasciitis. So if we briefly look about the differential diagnosis, scleromyxedema, which is the deposition of the amorphous mucinous material in the dermis, causing the thickening of the skin and the appearance of yellow-red waxy papules, which is associated with the monoclonal gammopathy. The second one is the sclerodema, which usually occurs in patients with diabetes who are on insulin and monoclonal gammopathy. It is the diffuse induration of the skin in the absence of autoantibodies and in the absence of signs of inflammation in the skin biopsy. The third one is the eosinophilia myalgia syndrome, which is due to the consumption of L-tryptophan and hydroxytryptophan supplements, where the dominant clinical sign is the severe myalgia compared to the eosinophilic fasciitis. And the skin damage is similar, while the visceral involvement is commoner than the eosinophilic fasciitis. The next one is the nephrogenic systemic fibrosis, which occurs in the advanced CKD. The differentiating features from eosinophilic fasciitis are it involves the hands and feet, eosinophilia is absent, and again it has a distinct histopathologic pattern. The next one is the toxicoil syndrome, which is caused by the adulterated rapeseed oil. The clinical features are almost same, but they have the increased CPK levels and the pulmonary infiltrates. The next one is the graft versus host disease, that is the sclerotic skin changes in any areas of normal skin or resolving lichen planus-like lesions, particularly on the medial arms and the thighs. The deep sclerosis with facial involvement and typical growth sign appears in the chronic disease. That is also, growth sign is also possible in graft versus host disease. So what are the investigations are we going to do? We have to do the routine and the special investigations. In the full blood count, we can expect eosinophilia, but it may be transient. Even in active disease, eosinophilia may not be there. Then inflammatory markers, both the ESR and CRP are high in more than 50% of patients with eosinophilic fasciitis. And they can have polyclonal hypergammaglobulinemia, immunoelectrophoresis to exclude the hematological malignancies which can trigger the eosinophilic fasciitis. And we have to do the muscle biopsy, which includes the deep muscular fascia if the biopsy is inconclusive or we can't perform the biopsy, we can go for the MRI. So what about the autoantibodies in eosinophilic fasciitis? Specific autoantibodies are usually absent, but anti-centromere, anti-topoisomerase 1, and anti-RNA polyisomerase 3 antibodies can be present in 15 to 20% of patients. And antinuclear antibody and rheumatoid factor are positive in 10% of patients with eosinophilic fasciitis. And we can do ANCA to exclude the eosinophilia with granulomatosis polyangiitis, which could be a differential diagnosis. So are there any criteria to diagnose? The last classification criteria was published in the Journal of Dermatology in 2018, which has the major and the minor criteria. The major criteria include the symmetrical plate-like sclerotic lesions present on 4 limbs. The second one is the absence of Raynaud's phenomenon and exclusion of systemic sclerosis. The minor criteria includes the histology of a skin biopsy that incorporated the fascia shows fibrosis of the tissue with thickening of the fascia and cellular infiltration of eosinophils and monocytes. The second one is the thickening of the fascia is seen using imaging tests such as MRI. So the final diagnosis is made when the patient has one major criterion and at least one minor criterion. So there's a severity classification also, which depends on contraction, limited movements, and expansion and worsening of the skin rash. The prognostic factors, if it is associated with the malignancy, if it is paraneoplastic, the prognosis is poor. And if it is associated with the serum aldosterone level and type 3 pro-collagen peptide levels, the prognosis is again poor. What about the management options? The management mainly includes the oral prednisolone 1 milligram per kilograms per day with the subsequent tapering, or if the patient is severely ill, we can give IV methylprednisolone pulse therapy for 3 days, which is followed by a high dose of oral prednisolone. The glucose-sparing agent or second-line agent is the methotrexate 15 to 25 milligrams per week. And the alternatives are the hydroxychloroquine and mycophenolate mofetil. For the refractory disease, if the patient is on high dose of prednisolone, which is 1 milligram per kilograms per day for more than 3 months and not having clinical response if the inflammatory markers, eosinophilia, also not coming down, it is considered as a refractory disease and we have to treat them with a combination of cyclosporine, D-penicillamine and photochemotherapy, which includes the ultraviolet therapy. The second one is the TNF-alpha inhibitors like infliximab. Third one is the cyclosporine in monotherapy and a combination of dapsone and the prednisolone, which is only for the refractory disease. There are some newer therapies available, sirolimus, which is the inhibitor of rapamycin kinase, and reslizumab, which is an infusion-based humanized monoclonal antibody with anti-interleukin 5 activity, which are for the refractory diseases. Not only the medical treatment, other modalities of therapy is also important, as this patient can have the contractions and they are prone to get the contractions due to the fibrosis. So we have to arrange the physical rehabilitation therapy. Then second one, we have to refer these patients for the surgical intervention of contractions. And if the patient is having carpal tunnel syndrome, we have to refer for the carpal tunnel tendon release surgery. And surgical fasciectomy, that is also reserved for the refractory cases. So how are we going to assess the therapeutic response? that is assessed clinically by the softening of the affected skin, that is usually by the same clinician. Then the rapid resolution of the eosinophilia and normalization of the ESR. Those are the markers of good clinical response. So at the end of my presentation, these are my take-home messages. Eosinophilic fasciitis is a rare connective tissue disorder and few cases have been reported till date, which is characterized by progressive symmetrical thickening and induration of the skin and soft tissues of the limbs. The joints, muscles, and rarely systemic involvement is seen. The diagnosis is based on clinical findings, presence of peripheral eosinophilia, and full thickness skin biopsy to show the inflammatory infiltrate composed of lymphocytes and eosinophils. Systemic steroids and immunosuppressive agents play the pivotal role in the treatment. Even it's a rare diagnosis which has a good response to the treatment, thus the early detection is important in eosinophilic fasciitis. My sincere gratitude goes to my trainer, Dr. M.K. Silva, consultant rheumatologist, Colombo South Teaching Hospital, and my dear colleagues, and moreover, my patient. Thank you. And I'm happy to answer if there are any questions. This is the groove sign that is mainly due to the fibrosis of the underlying dermis, which reshorts the skin, and this is along the basal path. These are the These are the pigmentation compared to the normal skin of this patient, and the body appearance is also there. Mainly after Thank you.
Thank you, Nirooshika, for your informative presentation. I feel dermatology see most patients of this kind of with only the skin and the involvement rather than the rheumatologist. That's why we see the realities of patients. Thank you for your kind attention. So our next meeting will be on 7th of June. Thank you.